Just let me know, Mr. Desai, जब हम live हैं.
Yeah, sure.
Sir, we are live now.
Very good evening, everyone. INTAS Women Health welcomes all the participants to this very unique initiative, which is a confusion to consensus, a very unique initiative which contains real-time case studies on sexual disorders. This initiative is taken up by the Sexual Medicine Committee, FSIAD, and in association with INTAS Women Health. So this session will be moderated by the chairperson of Sexual Medicine Committee, Dr. Neeraj, and Public Relation Affairs, Dr. Apurva. So before starting this session, we will have a wonderful moment. We would like to unveil the theme video of FSIAD. This is entirely a new theme video for new committee of the FSIAD. So it's very exciting moment for all of us. So now we will have the theme video. I will request Rohit to play that. Rohit.
Dear friends, FSIADians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FSIAD. The 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world. Just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FSIAD's commitment towards women's health care. FSIAD for all, always.
FSIAD for All is another inspiring campaign. What you do in this organization
Play.
Hello.
Wait.
No problem. Good evening and welcome to everyone. So after a grand successful masterclass series with INTAS people, a total 6 episodes we've done in the masterclass series, we are back again with a new series that is a totally case presentation or clinical based scenario. And this is a C2C, means confusion to consensus series. And here we come coming with the first session of the series, and that is on female interest or arousal disorder. And for this first session, we have wonderful person with us, Dr. Madhuri Patel, Secretary General of the FOXI. She is the, I think, first female Secretary General of the FOXI in the history of FOXI. She was Joint Secretary of FOXI in 2009, former committee member of the FIGO preterm birth. She is Associate Editor of the Journal of the Obstetric and Gynecology of India. She is the honorary clinical associate in the Wadia Hospital, Mumbai. So I welcome you, madam, and please bless us with your words. Over to you, Madam Madhuri, madam.
Neeraj, am I audible, Neeraj?
Yes, madam, we are audible.
Yes. Thank you, Neeraj, for your kind and warm words. Respected Dr. Shanta Kumari, President FOXI, Dr. Bipin Pandit, Vice President FOXI, Dr. Neeraj Jadhav, Chairperson Sexual Medicine Committee FOXI, very meticulous, sincere, and down-to-earth personality. Our great speaker, Dr. Anita Sham, integrative psychiatrist and clinical sexologist. Our moderators, again, Dr. Neeraj and Dr. Apurva Kumar Datta. Then Apurva is public awareness in charge, SMC FOXI, and all my dear friends. Very good evening to all of you. I would like to express my heartfelt gratitude to Dr. Shanta Kumari, Dr. BP, Dr. Neeraj, Dr. Anita, Dr. Apurva, and entire team for giving me this opportunity. I would like to mention something about FOXI because we are at the FOXI platform. So FOXI is the prestigious, most vibrant, and one of the largest OBGY organization in the world. We have 37,500 plus members and 262 member bodies. FOXI mission is to support and protect OBGY practitioners in India. It encourages dissemination of knowledge, education, and research. FOXI serves to advocate sexual and reproductive health and rights of women. And the primary mission is reduction in maternal mortality and overall well-being of the women. FOXI has two academic wings, ICOG and Journal of Obstetric and Gynecology of India. In ICOG, we conduct the college activities and we conduct the training and certificate courses. ICOG has membership and fellowship. Now, Jogi is bi-monthly issue. So there are 6 issues in a year. And as soon as a new issue comes out, we send the SMS to all our members with the link so they can access the journal completely. Then all issues are uploaded on our FOXI website as well as the Jogi website. Our website, I am telling because there are so many people around, it is www.foxi.org. And I'm happy to share that our website have the journal issues right from 1950. So you can access our journal really diligently and you can take whatever material you want. FOXI distributes the journal to all its 37,500 plus members free of cost. Because of the COVID pandemic, we could not print the journal. Now the situation are coming under control and we'll start printing our journals and you all will be getting hard copy of the journal. During COVID pandemic, we have launched the e-journal, which is also available on our FOXI website. Now we have 27 committees and chairs. And Dr. Neeraj Jadhav, being chairperson of Sexual Medicine Committee, is doing excellent work. Every time he calls me, Madam, I have to do this, I have to do that. I say, I'm there, you do whatever you want. I will give you all the assistance from FOXI. Now, COVID-19 has adversely impacted the society, particularly healthcare sector. But at the same time, it has given us opportunity to learn and interact with our faculty by just sitting at home. Some people just lie down, some people just cook, and they are listening to the webinars. So that is the opportunity we have got because of the COVID pandemic. Now the women are always thought to be passive partner in sexual activity. Their sexual dysfunction and problems are largely unnoticed, unstudied, and untalked. Unfortunately, we are often getting this patient in our day-to-day practice. Moreover, no basic medical syllabus teaches us how to treat sexual dysfunction. I congratulate Sexual Medicine Committee under leadership of Dr. Neeraj Jadhav for being out such important topics and for starting this masterclass series to give basic knowledge to medicos to identify and treat sexual dysfunction. We have eminent speaker Dr. Anita Shah and moderators Dr. Neeraj and Dr. Apurva who are going to enlighten us on today's subject, that is on female sexual interest, arousal disorder, from confusion to concession. I am told that it is a case discussion, hence it is going to be very interactive. Neeraj has kept only 1.5 hours, but you will have to tell your technical person, and I'm sure it will go to 2.5 hours. I wish team best of luck. As a Secretary General, I would like to mention that for any assistant in FOXI, please feel free to contact me. My details are on our website, www.foxy.org, and please give me opportunity to serve you. At the end, I would like to quote Albert Einstein. Education is not the learning of facts. Education is not the learning of facts, but it is training of our mind to think. Thank you once again.
Thank you, Madhuri Madam, for your such a nice and kind words. And I know you are always available for any kind of help, any time of the day. You are there. Just one call, you are there to help us. So thank you very much from Sexual Medicine Committee. So,
Neeraj, I would like to mention one, on the lighter note. Neeraj was telling me, Madam, I am not getting a sponsor and I am surprised to see your sponsor today. So I said, I will give you Zoom platform of FOXI. You tell me whatever you want, I will give you. And he has done many programs with FOXI Zoom platform, and I'm very happy that Lay, you have supported the FOXI, and we wish you also best. And we always, we are looking forward for the another, such collaboration.
Thank you, madam. And this is a series of 7 episodes, madam. C2C, we have a total 7 episodes. Today is the first session of this series.
Very nice. Very nice.
7 sessions.
Very nice.
So, Apurva, now time to introduce our today's faculty. Please introduce and start.
Thank you so much. First of all, thank you so much, Madhuri Patel, ma'am, for your blessings. I mean, in a true sense, she is an example of women empowerment. She is being the first female Secretary General of this largest organization, which is, the dated back in 1950. It's more than 70 years. Ma'am, you are being inspiration for all of us, especially the youngsters like me. Thank you so much for always the blessings and your for precious time. Thank you, ma'am. So time to introduce our own Anita Shyam, ma'am. We all know because we have a lot of program with her. She is a great academician. Ma'am is integrated psychiatrist and a clinical sexologist. So welcome, ma'am, and thank you so much. We all are here to hear from you and to have the case discussion from you. So my dear friends, without wasting the time, it's the time to begin our scientific program. So the topic for today is the female desire and interest arousal disorder. And this time we are planned something different. And this difference is that we are not going to teach you the topics wise, but we are going to teach you the actual clinical series, actual clinical cases. So I am very glad that ma'am has done Anita ma'am has such a tremendous work. We have a 14 live cases which are based on this female desire and interest disorder. And by this, we are telling you how to deal with when these type of cases are coming in your OPD, in your day-to-day life. So welcome, ma'am. Thank you so much. And ma'am, over to you to share your slides. Over to Anita, ma'am. Anita ma'am, just sure.
You
You have to
unmute
unmute yourself, ma'am.
So, thank you. I hope you guys can see my slides. Thank you, everybody. Thank you, Dr. Jadhav. Thank you, Dr. Patel. I have wonderful memories from Wadia Hospital back during the residency days. It was such a refreshing conversation just now, and I really have very beautiful, loving memories of Wadia Hospital. So thank you so much, ma'am, for reminding Wadia, especially Wadia Hospital to me. Thank you, Dr. Jadhav, for this opportunity. It's a vast topic, and I hope I do full justice to my presentation today. And if in case I am not audible, I'm too fast, please stop me. Please ask for explanations, because my goal today here is not to teach you about what is interest in arousal disorder, but how to actually manage clients. And that is the focus of our presentation today. My name is Anita Sham. I was trained at JJ Hospital back home in Bombay. I was trained with Dr. Vatsa, Dr. Bhatt, and of course, my loving Dr. Gumaste also, and many other professors. So I've been very fortunate. I had wonderful gurus in my life. I still go back to my teachers all the time, and grateful for all their teaching. These are my disclaimers that I'm doing a presentation for Foxy. I have no financial, I have no other commitments. This is a completely academic presentation. Starting with our topic, friends. So let's desensitize ourselves with looking at these wonderful pictures. Our media, specifically our movies, Bollywood media, has been a good learning lesson for all of us. Each of these pictures are not to show you any type of pornography, but each of these movies, if you can go back and look at these movies, you might get to learn about every case you've seen till now. And that's why I have put this case. This particular slide of mine will talk about the biopsychosocial model, which is the etiological factor of desire disorders or sexual functioning. It is also where it will help you to formulate a treatment modality. So please look into it. And whenever you get a chance, please make sure you watch these movies. And there are multiple more. Again, our topic, our treatment, evaluation, all depends on what is the biological factor, social, psychological factor. But I'm going to straight go to my cases, because that's more interesting than going always to the theory. You are a gynecologist, you know the various stages in a woman's life where there are hormonal fluctuations, there are different roles a woman have to play, and above all, childbearing, being a mother, a sister, a housewife, a lot of roles, and that is kind of very stressful as well. So this is also about the various hormonal changes in a woman's body. Now, why this is really important is because it is accepted and it's expected out of a woman to play these roles, still be sexually functioning, still be on top of your roles. And at times it is a reality check that it's not that easy. When you have hormonal fluctuations, you have different roles in your life. It is a stressful situation for a woman. This is a response cycle. Please go through it whenever possible. It will help you again to understand the various sexual functioning, why sexual disorders happen, what are the various stages of disorder, and where your treatment can help you. Definitions, I just have to put the responses of a sexual responses depends on whether the response is a responsive desire or an adaptive response. Why I say that is because the desire, arousal, orgasm, and resolution, the 4 stages of sexual functioning, is very important because each and everything is so linked. there was a model initially created where it was a linear model. The desire was followed by arousal. Arousal was followed by orgasm, and then was resolution. But Dr. Bassin's cycle, the response cycle, talks more about a woman who is completely in a neutral state, not thinking, not wanting to have sex, can respond to an arousal state, and that becomes a responsive desire. And at times, responses can also be adaptive. In certain situations, a woman can be aroused and can have desire for sex, and that is called an adaptive response. Adaptive response, friends, can be positive and can be negative, and that has been my clinical experience also. And let me explain what an adaptive response is, because again, it is going to help you formulate your treatment modality. Now, imagine a case coming to you. A couple walks into your clinic and the woman doesn't have desire. Okay, that she says, I don't want to have sex with my husband or my partner. Dig into the history. There could be a case where the husband is alcoholic. He walks into the house completely drunk and expects to have sex. Now this woman has an adaptive response. Well, I don't want to have sex with you because maybe you're stinking, you're very abusive, you're very violent. It's a negative adaptive response, and that comes to you as decreased sexual desire. A positive response can be, hey, my husband walks into into the house. The husband kisses me, cuddles me, give me the warmth, and now I'm ready for sex. That is an adaptive positive response. So the reason to share this is, it's always good to know what is the reason for this sexual dysfunctioning. Again, this is a description of what a desire is. It's a three-way component. It's a three-way component: biological factors, psychological factors. It is not strictly biological, friends. Time and again, research has proven that the desire is not driven by biology. It is a lot of psychological factors, upbringing in the person, the religious belief of a person. It's not just, okay, you give an hormone, boom, the sex desire has come. In a woman, we have to also find out what motivates this woman to have sex. Not necessarily, and let's not put restrictions and boundaries to sex, saying that only married people have sex. Sex can be premarital, can be off-marital, extramarital, can also be an open relationship. So these are a few factors where women or anybody basically will be involved in a sexual behavior. Is it for warmth, commitment? Is it for self-esteem? It is for resources. Somebody wants a job and that person wants to have sex. Is it a resource? It's an expression of love. It's an expression of relationship. Is it just for pleasure? And mind you, friends, we will, as professionals who are in this field of sexual medicine, you will have clients come to you who say, I have sex with other partners just for pleasure. There is no reason, there is no bonding, nothing. It is simply pleasure, and it should not haunt you. So, and experience seeking. I had enough sex with one partner, or I'm done with my husband, so I want to explore other relationships, other partners. So these are various reasons people have sex or women have sex. Aging is a factor which can affect our sexual functioning. I think more than me, my gynecological friends, you all know this, how hormones affect. Also various psychiatric conditions, all physical conditions can affect sexual functioning. Illnesses can affect chronic illnesses like diabetes, hypertension. We have other postpartum issues. We have hormonal issues. So you can read whenever possible. When you, this is again, quickly let's browse to it. This is evaluation, why you need to take a good medical history, psychosexual history. What are the etiological factors? What predisposes, what precipitates, and what maintains this problem? Everything is possible with a good history taking. A good time-consuming history taking can give you success in your cases. A lovely flow chart, doctor who are treating can come to a proper diagnosis by taking a psychosocial evaluation or a medical evaluation. Again, go through it. Specifiers are, is it being long-term, acquired, short-term, generalized, in certain situation with all the partners, some partners in particular mode. I have clients who come to me saying, Madam, I can only have sex when I'm on vacation because I feel stressed in the day-to-day life. That is situational, and it is completely acceptable. You have to come up with strategies and come up with making their sex life more spicy. And there, in that situation, psychopharmacology doesn't work. Just go through it. This is the model, and I want to. This is another. I should say, factor you have to look into. Sex play or power struggle. Many a times, and I think if you've read mythology, Indian mythology talks a lot about woman power and how sex intimacy can be a controlling factor in a relationship. So when a client or a couple comes to you, you might also want to check, is that a control issue? Is it a power struggle issue? I just wanted to put that. Evaluation should have physical examination, gynecological examination, blood work, specifically hemoglobin levels, checking anemia. Vitamin mineral deficiencies are a very common cause of decreased desire, decreased orgasm. Glycemic profile, thyroid functioning, prolactin levels, and testosterone. I think we all know this, but just putting there. Evaluation model. Guys, I want, if possible, go through this slide one more time. And specifically the second point. As a physician who deals with such intimate issues, such delicate issues, you should be a vessel for your client. Your client should be comfortable and they should feel welcomed discussing their sexual issues. And a very common strategy or a very common way to put this is you should be a vessel of a vessel for a client to come and talk. And this vessel can be filled with negativity, positivity, any type of information, history given by your client. The client should feel, yes, I can go and pour myself to this doctor. So give them that permission. As soon as a client walks into your clinical setting with that comfort and love, give them the permission. Yes, you can talk about sexuality. You can talk about sex life. You can talk about your partners, your fantasies. Give them limited information. I think you might want to look into this. You have decreased desire. And I think this particular treatment can help you. And this model is very important because you never know if this client is going to come back to you. So give them the permission to come and talk to you. Give them information and specific suggestions. And if they want to come back again for more treatment, more than welcome, but at least they have something. This is going on in my relationship. Move on, friends. Distinguishing between organic factors and psychogenic factors. A beautiful flow chart about how if a doctor is dealing with an organic condition, a physical condition, or a psychiatric problem, and then the flow chart, how the treatment works. My first lovely case.
Purva, you go with the first case.
Yes, Ji.
Unmute yourself.
So after this brief introduction, what all about is the interest disorder, arousal disorder. Now it's coming to the live cases. So I will take the first cases. A 20-year-old married woman to a 24-year-old businessman is accompanied with the husband for low sexual desire. Husband is very loving and caring and a successful businessman. In-laws and other family members are very caring. She refuses sex all the time. Next, please.
So how will you just
manage this case? Yeah.
And then manage patient. First of all, how will you?
This is a case, a couple, everything is okay. There is no financial burden. The husband is very caring. There is a nothing problem from in-laws, but she refuses sex. So how will you deal with this type of case when this type of cases is coming in our OPD? Yeah, Anita ma'am.
Yes. Apurva ji, thank you so much. So this was a case presented to me by a doctor from Punjab, and we had a teleconsultation. So the first jump or the first treatment which this doctor thought was, Madam, can I give her flibanserin? And I said, wait, let's look on what age factor are you dealing with. So this is a young woman. This is a young woman who is married. Now, 20-year-old, you're talking about somebody who was still in college. So you might want to dig into a question: was she forced into this marriage? Was she willing for this marriage? Secondly, you also want to find out from this young, wonderful lady if she had some goals in her life. Was she wanted to become a professional, and all of a sudden she was put into a marital situation. So these are very important factors. First is to dig out what role does she play? What are these factors? After this, you come to, did she ever have any sex education? Did she know what sex is? Does she have fear about sex? Now, she refuses sex all the time. Why? What does sex mean to her friends? Because at this point of time, because she's very young, she is bound to be more sexual. She wants to be more welcoming to her husband, but she doesn't. Right now she doesn't want to have sex. So you need to first find out if this person has any anxiety towards sex. Was she forced into this relationship? And after that, the treatment starts is giving them sexual education, sex therapy in terms of how they can get sex into their life. My first strategy in this patient would be connecting yourself first. So if this person, a good question to this client and this husband should be, have you ever masturbated before? What does sex feel like? Have you experienced what orgasm is? And if that is the case, your first step will be giving them that limited information and guidance that explore your bodies, because sex is not all about intercourse. Psychosexual education starts there, is giving them the complete knowledge of what sex is, what different forms of sex is, getting more detail into intercourse. And I think this case can be handled very easily because I did it within one session. It is simple psychosexual education to this client.
So in such cases, most of the time it is due to fear of the sex. Main reason is the fear of sex.
Fear of sex and a completely lack of knowledge, Dr. Jadhav.
Yeah.
Ma'am, what you are talking about the psychosexual, the education. What education in simple term, what we should teach our patient, because the problem with this type of things I am telling you, because this type of patients have usually come to us, the gynecologist. We have a busy OPD, we have the OT and everything. And the most important problem with that, we doesn't give the adequate time to ask the question. So in that particular, that 5 or 10 or 15 minutes, what type of psychosexual education which we should give to our patient in this type of patient? Ma'am, just topic. Yeah.
The most important thing, Apurva, in this particular client and basically all the clients, is talking about basic anatomy and physiology. That anybody can do. Talking to them about the 4 stages of sexual response cycle. Okay? And then talking about the different part of the body which are very erotic and very sensual. If you can tackle these 3 steps, Apurva, your treatment is done most of the time. And the patient will, oh, so this is how it works. So it's not about just my penis entering the vagina. It is much more than that. So you can tackle this in 3 ways. Give them education about anatomy, physiology, give them education about sexual response cycle, okay, and talk to them about various forms of sex. 5 minute ka kaam hai, Apurva.
Yes, ma'am. Thank you so much for dealing this so lightly. So Neeraj, the next question.
Yes.
Yeah.
So this is another case. 28-year-old pregnant woman accompanied by her husband and wife has a low sexual desire. So how will you deal with such type of patient? Because in generally, in India particularly, when you are pregnant, most of the time it is advised that you don't have sex regularly, because there are so many, as a clinician, we hardly talk about the sexuality during pregnancy. And in-laws and everyone, they also tell not to have abstinence during pregnancy. So naturally there will be a low sex drive in a pregnancy. So how will you tackle this patient?
And thank you, Dr. Jadhav. Wonderful case again, and I agree with you. There is so much of anxiety and fear with sex around pregnancy. It is because loss of child ho sakta hai, kuch harm ho sakta hai. There are so many things, and this again comes to a fact that there is lack of sex education. There is lack of knowledge about sex. So, agar we talk about a pregnant woman and we know about the three trimesters. First trimester, of course, there could be reasons the woman is having nausea, vomiting, physical symptoms. So she is not interested in sex because of these changes. Okay. But there comes a second trimester, which is much safer, which is women are more settled in their physical symptoms. And that is the time as a gynecologist where you can start talking about how you can incorporate sex into their life, intimacy into their life. And I must tell you also here, Dr. Jadhav and my friend, that men also feel lonely when women are pregnant. Yes, because there they are completely lost of all that emotion, the attention they were getting as a partner. So as a gynecologist, friends, it is a very important or a very big duty on you to have these couple talk about sex, how you can guide them bringing sex into their life, talking about various safe sex positions. Okay. Positions where the husband is not lying on the wife and there is less pressure on the uterus and on the baby, right? Talking about different position, which is a side or spoon position, which is a very comforting position, very nurturing position. So as a gynecologist, I think you guys should really learn about various sex positions which are safer during pregnancy, okay? And again, make yourself that vessel, a welcoming doctor that, hey, I understand you might be going through this. Let's talk about this right now. I know your wife had vomiting, very physical symptom, but this is a time when you can reconnect, because as professionals, we know by the time the second trimester comes, the husband wife, they start separating in their emotions. It is becoming more like we are pregnant hai, dhyan rakho, ye karo. There have been literatures where sex intimacy involved during pregnancy have shown good long-term sexual results. In fact, this was one of our case at Harvard once, that a husband came to the clinic because he had decreased sex desire. He said, I feel lonely. My wife is pregnant and doctor, I feel I have fear of having sex with her. We can harm the baby. So there have been immense literature that sex doesn't harm during pregnancy, provided you use safer sex position. You don't try something very vague and risky, but continue enjoying sex as professional, encourage them to enjoy sex. Lastly, when we reach the third trimester, okay, how have we not heard about oxytocin, the loving hormone? How important is it for our uterine functioning, for even for contractions, for labor? In fact, if there was a literature a couple years ago, I was reading how doctors encourage the clients to be involved in intercourse because of the beautiful hormone oxytocin. So again, comes to us as a responsibility. We need to know our knowledge. We need to have complete knowledge in sexual functioning, and that what you can guide the clients. So in this particular client, I'm going to give them again education, giving them complete information about what is safe sex, what a safe position, and encourage them to be involved. And the low sex desire will be gone.
here also low sexual desire is because of fear only, or is there could be any
Yes.
other factor also?
Sir,
Less likely, doctor, less likely in this particular client if we have ruled out all organic factors, doctor.
Which are
okay? It can be all the gynecological risk factors. We have eclampsia, preeclampsia, we have different placental positions. So there could be a lot of organic factors, diabetes, hypertension, even in women. If all those are ruled out, and even if those are there, having safe sex position, having that sexual knowledge of what sex is, intimacy is, can really help in these clients. They don't need any pharmacological treatment. They don't need any lubricant, nothing, because with this knowledge, these cases can be tackled.
Just by explaining the patient, we can improve the sexual desire in such type of patient.
Yes. So imagine, Dr. Jadhav, you just mentioned during the case, during the introduction, how our parents, our relatives know having sex, so it is dangerous. And then even the poor husband has a big burden. Oh my God, I'm going to hurt my wife. Or the wife has a big burden. Oh, I'm going to hurt the baby. That is all fear and anxiety.
Okay. One more point which I want to add, because in some culture there is a culturally they are motivated that during pregnancy you shouldn't have the sexual intercourse, because I have one patient like that. What the husband want, but the wife doesn't want. She also want, but her grandma told her that because if there is a female child in your home, and if at that time you have a sex with your husband, then logically that the husband is having sex with the kid, the girl child. I don't know. There is maybe, but there is some cultural factor is also there. I think so. In some society, some culture, there is a bound. If it is a pregnant, don't do for that.
Sometimes what happens, Dr. Anita, even if we advise that there is no harm in doing sex during pregnancy, but suppose in by chance something wrong happens, they will tell us because you advise and
yeah, actually, definitely, sir, definitely.
Sometimes issue is that also.
Okay, sir, I think we should.
Yes, sir.
One minute. So, Dr. Jadhav, that is so very true, and that's why you need to make sure you yourself know what are you advising. Are you advising, like if you're advising your client for a woman up position, the man down and the up position, you need to make sure to tell the wife that you don't have to be very robust, you don't have to be very strong, and you have to don't do very fast, and give them all that information and knowledge. Enjoy. Yahan pe you're not running a race. It's not a like very simple horse galloping. It is a beautiful relationship. Enjoy your sex. And that should take care of it, because I know we all want to save ourselves ki kuch ho gaya to patient hame pakadenge, but that will not happen, sir. No. If you follow, you should tell the client, you follow these guidelines, be gentle.
Okay? No, ma'am, the problem is that na, agar किसी भी चीज से होगा ना, तो उनको यही आएगा, नहीं डॉक्टर ने मेरे को कहा था to have a sex. Whether it is whether is the cause is some utterly anything, but they will tell that no, doctor have told me and that's why it was happening.
Because and then in such type of cases, it is more important to tell to explain the mother-in-law and them also. We should explain them, because it is much a
I know, Dr. Jadhav, we can go on and on, but imagine अगर mother-in-law को बुला के आपने बोला कि you know what, it is safe to have sex, second trimester है, ये position से बोलेंगे ये डॉक्टर के पास जाओ ही मत, ये तो आपको गलत. But as you know what, as having that responsibility as a sexual medicine specialist, we have to tell them, you are my client and this is the right information I'm giving you. This is the right research, and sometimes you can just hit research also gives you these informations. Safe sex, continue your intimacy, safe sexual positions. works wonders.
Right. So next case, Purva.
Yeah. So with this discussion, we are coming to the next case. Young couple presented 6 months after the marriage. The women is complaining of not interested in sex for last 4 months. Now here there is a catch. Initial 2 months they enjoy their sex, but last 4 months only. After 2 months, they are not they are not have desires to have sex. On examination, there is a hollow pouch near the urethra of a female. So, ma'am, next question is that what is there any anatomical defect or if there is a hollow pouch in the urethra? What you are taking in this case is the anatomical defect is the cause of not having sexual desire. Over to you, Anita, ma'am, and how to deal with this case.
Again, Apurva, wonderful case, and I must tell you, this can also be tackled very easily. My gynecological friends, you know more than me in this case, but let's take this case. So here is a case who presented 6 months after the marriage, woman not interested in sex for last 4 months, and she has an hollow pouch on examination. Well, we have the diagnosis here. It is a urethral diverticulum. Anatomical defect, very rare condition, can be treated surgically. Well, when this starts as a cause, okay, a cause for the sexual dysfunction, what it really does, a woman can come and complain कि बहुत जलन होती है sir sex करते हुए madam. Secondly, पेशाब की बदबू आती है तो मुझे अच्छा नहीं लगता है sex करते हुए. या फिर the woman can complain of pain while intercourse. And a lot of physicians do not know about this condition. They might think it's vaginismus, it's genitopelvic condition. Certain key questions, friends, can take you long way. पेशाब की बहुत स्मेल आती है या कॉन्स्टेंटली आपको इन्फेक्शन रहता है, राइट? और पेन कहाँ पर होता है? आपको मन करता है कि आप बार बार पेशाब करो. When couple of these questions are there, you will like, oh, you know what, this would be an organic condition. Okay, and this organic condition can be seen by, we have ultrasounds, we have physical examination. You can do this surgically tackle. From my side, how do you tackle the sexual side effect? Like, how do you tackle on the sexual side? Again, sex therapy, friends, sex therapy. Educating the friend about this condition, telling the client that there is a treatment available surgically for the sexual side. If you have pain during sex, be very gentle. Focus on basically more of arousal. When the body is aroused, that means there are physiological changes having in your body. The woman is lubricant. There is lubrication in the body has the warmness, and the body will not experience severe pain. उसके बावजूद, if a client says, no ma'am, I एक हफ्ता हो गया, madam still बहुत pain हो रहा है, then we deal with, we talk about, there are lubricants available, there are water-based lubricants available, which they can use. They can use topical ointments, which can reduce the pain, right? If there is an infection, tackle the infection first, because that will take care of everything, okay? After that, if the client still complains, we talk more in detail about what are the various sexual positions which are not deep penetrating. Okay, so less deep penetrating positions could be women on top, because she has more control over her movement, and there can be less pain. Or you can use the spoon position, because that will cause less pain. But here, this is an organic condition. It needs to be treated. Infection needs to be treated. Guidance about various sex position. Okay. Full knowledge about this condition is important. And also, sir, I also want to add one more thing here is about genital hygiene. If this client comes to you and she says, मुझे बहुत embarrassment होती है मैडम, और बहुत पेशाब की smell आती है body से, there are certain things you could guide these clients, friends. And this is what I do in my practice. Make sure client को कहो कि भाई can you take a shower before you have sex? Like have a planned day for sex. So हफ्ते में अगर आप 2 बार plan करते हो, so before you have sex, try to wash yourself with warm water, not soap, because that can cause over dryness. So this is again which I want to tell my gynecological friends. Please tell your clients not to use soap, harsh soap, because उनको लगता है जितने अच्छे तरह से wash किया, gentle washing, this will help you to feel clean. This will help you to remove the smell. So that is one topic, that is genital hygiene can be taken care of. And again, surgical intervention in this condition, gentle hygiene, guidance about deep avoidance of deep penetrating positions will help. And again, talking to them about how desire, arousal, orgasm, and resolution works. Very, very nice case, sir.
Next one, please. This is another case. 28-year-old female patient accompanied by the 32-year-old husband. He has some sexual concerns, but she says, I don't feel the desire and need to have sex. So how will you tackle this patient?
Okay. So once in this particular client, sir, it looks like they might be married for a couple of years. Yeah. So you need we have to again dig into take a good history here. History of, is there a biological condition? So that means a good evaluation on the biological side. Diabetes, hypertension, thyroid functioning, any type of infection in this client. If we've tackled the organic cause, then we come to psychiatric causes or psychological causes. Is this client suffering from depression? Is this client having any form of anxiety or fear? Okay. Any other sexual dysfunction associated with it? Like is the client having vaginismus, genitopelvic pain disorders? So any other causes? What are their relationships? A very good thing would be if they are married for a few years, how is their relationship? Do they talk about sex? Because sexual communication is also a key factor. Do they feel motivated for sex? So all these issues, and then of course, cultural factor. If I remember dealing with such a case, the woman didn't want to have sex because she was always surrounded by in-laws in the house and there was no place to have sex. So even to know, how many people are in the house? Do you have a private place in the house? So this will tackle your psychosocial model of diagnosis. Now, when it comes to treatment, there are 4 ways you can handle this. And again, a good history will really help you. So if there is absolutely no desire, then that means there is a biological factor involved. So in a biological factor, you need to maybe this client would need, if she's depressed, you need to give her some antidepressants. So refer her to the guy to a psychiatrist who would know. Again, good psychiatrist who would know prescribing an antidepressant which has less sexual side effect. We have wonderful drugs, bupropion, buspirone, beautiful drugs which have less sexual side effects. If there is anxiety, buspirone works very well. That is depression factor. Second factor is if this client has vaginismus, so look into genitopelvic pain disorders. Agar wo hai, then you have to treat in terms of the vaginismus factor, vaginal dilator, more of sexual stimulation, more of arousal. Okay. Also, if there is, like, if we have factors like घर में बहुत लोग हैं, बहुत in-laws हैं, then you would want to guide them to have sexual commitment in terms of sexual calendars, couple 2 fixed days as a commitment to have sex, or to encourage them to go on vacation, have a vacation sex, and guide them into spicing up their sex life. So this is how I will tackle this case. Look into the biological factors, look into the psychological factors, look into the social factors. Biological cause, treat the organic cause. If there is psychiatric cause, depression, anxiety, treat that, and that will take care of it. And if there is a social factor, you can work into sex dates, sex vacations, So this can be taken care like this.
So only with the counseling we can manage such type of patient. No need of any drugs or unless she is suffering from depression. No
Yes.
need to prescribe any drugs or.
For this case, sir, I would not. This is a phase of life in women. I think this couple would have had kids, so there is a different role in this lady, or this lady is being married and want to look into a career. That is also another cause. I have seen women having decreased sex desire. So a different role, but again, no medication needed unless and until there is a cause. Organic cause, depression, any type of thyroid functioning issues, which we have to be ruled out. But if you talk about flibanserin, release, none of these things will help.
What about DHEA? Any role of DHEA if such type of patient is having a lot of sexual desire?
DHEA. That is something, that is a very interesting drug, sir. But for this client, no, we can certainly try. There is formulations available, but again, unless and until we have ruled out those organic factor, biological factors, I haven't seen much result with any of these, sir.
Okay, so mainly when treatment will be of the counseling. Sexual counseling.
Right? Sexual counseling, and sir, of course, explaining to them what sex really is, because all the time it is so mechanical, because we have another case and we'll discuss in more deep. It becomes so mechanical. Eventually, when everything is so spiced up, everything is so lovey-dovey, and dire as the age goes by, the sex goes down. So you have to keep it, spice it up, and you have to keep on educating your client that, well, this is going to happen. So you need to find different ways and more to spice it up.
Ma'am, here I just wanted to add two things. First of all, not two, the one thing. When the baby have kids, after that, there's two things in their changes which I feel in my patient. First is the bodily changes. And many times...
That case also. So we'll discuss it.
Okay. So in the next case, we will deal with that. Okay. So next, please. So here is our fifth case. A 26-year-old woman presented with reduced libido, separated with the boyfriend since last 3 years ago, recently found a female partner, initially more interested in sex with her, feel she is not woman anymore. Now, ma'am, these type of things is previously it was just like कि भाई ऐसे तो होता ही नहीं है. But nowadays, when we seeing the case, is a more type of this type of peoples and this type of complaints are there where the people are actually not very confident about their sexual orientation. So, ma'am, when we get this type of patients, how will we deal with this type of patient? Over to you, Anita ma'am.
Yes, wonderful case again. Okay, and so not uncommon, Apurva. Nowadays it is very common, because there was a time where we, if just giving you a little brief of what it is. Now we talk about sexual identity and sexual orientation, which has a lot of biological factor, which have preferences and your intention. So there was a time where it was strictly homosexual or heterosexual. Now it is bisexual. So even and I don't like to use the word straight or normal, but even an individual who is married, having in a heterosexual relationship, can be attracted and can feel like having sex with the same sex partner. Okay, it is definitely possible, and it can change from time to time. So I have clients who come to me all the time with these type of I would say not problems, not complaints, but they just come up with these issues asking, is that okay? And that is completely fine. If somebody was with a boyfriend, you don't know what relationship he was having with the boyfriend. The boyfriend was too controlling. The boyfriend was very abusive. Okay, She broke up and she found somebody who's a woman, who's very comforting, who's very loving, affectionate, and there she feels, oh, you know what, I am attracted to this person. So there has been a change in the orientation now. Again, very normal, again, very common. Is that a problem? No. Does it need to be treated? No. It is something, again, to work with psychotherapy. And this is called as psychosexual therapy, where somebody who deals into psychodynamics can rule out what is really going on with these preferences. Her saying that I don't feel a woman anymore, again, this came to me 2 or 3 weeks ago when this client, a very young client, was attracted to females, okay, women, and she said, I don't feel a woman anymore. Now, does that mean this woman wants to go a surgical change or hormonal change? And the answer was no, because it is just a time frame. She, at this particular time, she feels that, she says, it is just a feeling, which is not a concrete. So my teachers, where I learned, Apurva and Dr. Jadhav and my friends, you need to first judge if this feeling is persistent, consistent, and how strong is this feeling. Okay, you might come up with a client who might say, I have never felt comfortable in my body. I've always felt there is a woman inside me. That is a strong feeling that has been going on since many years, and that is called persistent, consistent. And then you need to evaluate. But if it is it is a thing like this, separated 3 years ago, recently found a woman, it can just be an affection. It can just be a momentary emotional connection. And as I said, sex is no more a penile vaginal intercourse thing. It is all about affection, love. And if my audience, my friends remember the movie Fire, the 2 women in that movie were not homosexual. It was just that situation which brought them together and brought them connection. So you as a professional, friends, need to really distinguish between, is this going to be a consistent, persistent, strong feeling, or it is just a momentary attachment to emotions. So those 2 things jab separate ho jayenge, you will get, your treatment is there clear, persistent, consistent. We need a psychiatric evaluation, andrological evaluation, endocrinal evaluation. No, it is just a momentary touch. Well, that's fine. Move on. And assurance. So if this is the other way side, Apurva, the assurance that, you know, it is just a comfort thing. You're not crazy. Nothing is wrong with you. It is pretty normal. Okay. Exactly. But those 3 words are very important. Consistent, persistent, strong feeling.
Very true. Actually, ma'am, this is the problem. And many a time what you have told, they have the momentary, and after that they are thinking of like that. In this particular case, same is with her. So we have a very important role to counsel our patient regarding if it is only momentary, then it is nothing. Maybe it as a momentary.
And one more thing I would like to add, my friends, is that if this feeling is at a very long time, okay, the person doesn't want to change, this person doesn't want any hormonal change, but it is constantly like a persistent thought process, one would also need to look into an OCD factor. Is it a compulsive thought which is coming? And that can be tackled with a medication, paroxetine, any of these things. But again, a good history will help you really formulate your plan in this case. Let's go on to one. I have 14 lovely cases. Here, Apurva.
Yes. Yes, sir.
Yes, this is another case. Young couple had a very happy sex life. They consulted a doctor for infertility for 1 year, but doctor advised time intercourse from day 12 to 18. This is a very common day-to-day scenario in our practice. So wife suffered from the lack of interest and described sex as a mechanical entry. So how will you solve this case? Because
yes. So again, a wonderful case. and it's just been 1 year duration. So this is a very nice, still a new couple. Okay, they have a pressure of, oh my God, bacha kab hoga, kab things honge. So again, I would start in this case with an history. Okay, history about what is their sex life. Is this marriage consummated or not? If the marriage is consummated, what is really happening? That starts with a different section of sex therapy, talking to them about the various phases of sexual cycle. There is desire, there is arousal, there is orgasm, there is resolution. Many a times, sir, I have noticed, especially in our Indian clients, they do not know about what a desire is, what is arousal, but orgasm they know. अरे अंदर जाएगा, aha feeling आएगी, ejaculate होकर खत्म हो जाएगा, and that kind of demotivate the woman. Okay, it is a very demotivating, because then you're feeling like you're just a pleasure object. जब आप ऐसा कोई client आपके पास आता है, you dig into the history, and a first sentence would be, what does sex mean to you? Okay, and there your flow chart begins. If sex means, sex क्या है madam, husband बस sex करना चाहते हैं, I have no feeling because I don't feel anything. Very common thing is because the women have not ever experienced orgasm. Why have they not experienced orgasm? Because here they think the husband is responsible to give them orgasm. Husband feels the pressure to give them orgasm. And they don't know that penile vaginal sex will not give them orgasm. So this is my specialty, and I kind of guide them towards the various techniques of sexuality, intimacy, and what are different forms of sex. I give them a complete sex education about how women anatomy. So you guys know anatomy more than me. So we teach them about where the G spot is. How does the penis enter? And that never hits the G spot, even if the person has the biggest penis. So education aspect is very important in this case. Talking to the client about how to move around the woman's body, how to stimulate the body, how to arouse the body will help this client come out of the mechanical entity factor. Okay, I am just not here to enter and go. I'm here also to experience pleasure. So when the client is thought about how arousal can be taken care of, touching the body, okay, feeling the body, smelling the body, tasting the body, okay, even the auditory stimulation, that causes an arousal. Now the woman is ready for having sex. Now she's enjoying it and guiding the clients. Now this happened 2 weeks ago with me also. The husband did not even know what is a clitoris and what an importance a clitoris can have in a woman orgasm. Okay, so educating the client about the anatomy of the person. Now, I know you might say, madam, मैंने educate कर लिया, clitoris बता लिया, sex positions बता दिए, सब अभी भी issue है. Okay, अभी भी issue है. In such a client, I would definitely look at a factor of depression. Now, why I say that? Why I say that? Because she has pressure from so many people. बच्चा चाहिए, बच्चा चाहिए. She possibly could be in a short term, just, mild depression where a small antidepressant can really work. We have bupropion, 150 milligrams would really help in this client. Once a day, start slow. Please don't start with fluoxetine, paroxetine, all those things, because yes, they have multiple side effects. Bupropion will work wonderfully well. Okay, I have seen even buspirone work if there is anxiety. Secondly, what can help if the desire is completely gone? Okay, with all the pressure, she feels like she is motivated to have sex, but there is no desire. In that situation, if it is an educated client, we can work with a very small dose, pea-sized dose of testosterone gel.
In such young patient, it will be helpful.
Young, sir, young matlab kitna young hoga ye? It is a very subjective term for young.
Yes.
Though FD,
this patient is around 30 years.
yeah.
They are taking the treatment for 1 year, infertility treatment.
Yeah. So maybe not, maybe in this particular case, not testosterone, but if you're talking about cases who are like around 35, 40, a small dose for a very short time will really help. Okay. We also look into the other factors here in this client. If she has gone through a lot of procedures for infertility, we have to check into the anatomy, the vagina, if there is any scarring in the vaginal side or the vaginal opening on. If that is the case, we talk in terms more of how we can arouse more, create more lubrication, use more jellies. Okay. Because I had a client recently, sir, where a lot of infertility procedures done cause a lot of scarring into this client, and that caused pain. So vaginal jellies help, tropical ointments will help to ease the pain, and guidance to them about how to enjoy sex than to make it mechanical. But most of the time, even I have seen some of my friends in India, if the client is around maybe, past a certain age, they usually give a very, very small dose, and and that to a very educated client only, because you have to monitor hormonal profiles, talk about something. A small dose of testosterone has been found helpful. And again, it is not to be put on the vagina or on the private parts or on the cut part. It is a very small dose. I think in India, gel is available for 12.5.
One injection is a 12.5.
Yeah. So trying to start with a very small dose on the arm, which is not a cut arm, but very small dose. Look at the client for around 2 to 3 weeks. And I have seen people really do wonders. See the client, see the desire, and gradually also taper it off in a few weeks, just to build up that desire level.
Next one.
Yes, sir. Next question is, a young couple married for 2 years, but never consummate. On the first night, didn't allow him to penetrate. He was anxious the vagina would not accommodate the large penis. He tried lubricant psychotherapy. The man didn't want to hurt her anymore. He started feeling depressed, difficulty in pap smear sampling. So this type of case we often get where actually the patient doesn't, it is an unconjugal marriage. So ma'am, how to deal with this type of patients? Is the psychotherapy, medical therapy, or should we go for any surgery or something like that? Over to you, Anita ma'am.
So dear, again, we are talking about genitopelvic pain disorder, if of course we are able to find it, diagnose it. But talking about young couple married for 2 years and not consummated, again starts with a good history, a history of what happened at the first night. Did the husband feel this is like a performance night for him and wanted to force sex? And that got this wonderful lady really fearful. Also, if there was never a penetration happened, we need to find out if there was any child abuse, any sex abuse in the woman, where she's very fearful of sex. Because there are two conditions here which we have to really be aware of. One is an aversion disorder, or one is a desire disorder. If it is an aversion disorder, then you have to look into the history, the past history, any form of trauma, any type of an abuse, any type of violence created. Okay, so if there is no aversion, like, oh, sex is disgusting because this is what it does. If that is not the case, the aversion, because if there is an aversion case, we have another psychotherapy, cognitive behavioral therapy is there, where you desensitize the patient, you kind of introduce sex in a more pleasurable way. But if you have a strict, we're talking about desire, then you have to look into if it is an arousal issue, or it has been an orgasmic issue, or what has been the cause. Because if she says that I fear, there is an anxiety towards the vagina, that it can hurt me, and the penis is very, very large, So there's this wonderful psychotherapy, and a lot of doctors use vaginal dilators. But what you need to understand is somebody who's already having anxiety or having fear with something entering, would she or he allow a dilator? No, they will not allow a dilator. So here again, we psycho-educate them about what is sex, what are the various sexual response cycle, start a stage therapy. The stage therapy, like the various protocol for this stage therapy is start with sensate focus. Okay, sensate focus may it is a complete pleasure based protocol, which is not demanding intercourse, not demanding sex. It is only having connection with your partner. The second stage of sensate focus is having more sexual or more sensual touches, allowing their partner's hands to go around the private parts. Okay. And lastly, the penetration begins. And I advise my clients, this is my advice. You don't have to buy expensive dilators. You have hands. You have hands. So your hands can work as dilators. So first, before the penis enters, let the woman be comfortable using her hand. Because even if, however, psychotherapy you can give, the client, "Arey, kuch nahi hoga," and it is just, it is enjoyable experience, be mindful. No, the practical side here is advise the client to use some water-based jellies and use hands. You train the client to use hands around her vulva, clitoris, and always remember, as soon as it becomes painful, as soon as it becomes uncomfortable, relaxation therapy. Take deep breath, which is stimulating your parasympathetic pathway. Take deep, relaxing breath, and then start stimulating again. After that, once the client says, "Yes, ma'am, I think I can touch myself, touch my clitoris, I can stimulate myself," you start with your pinky. After your pinky, and a pinky should also be externally, and then you start grading to multiple fingers. This process can be then moved on to the partner, and by now the client is very comfortable letting the touch or letting anything introduced. But in this client also, Apurva, psychoeducation will help, sex education will help, and a practical behavioral therapy will help in this case. If she is depressed, again, depression can be caused because she doesn't feel that I can provide sex or I can enjoy sex. If this is taken care of, the depression is gone, sex is back in life. Okay, because I have to tell you one thing, Dr. Jadhav, I have seen so many physicians who first thing उदासी आती है, थोड़ा उदास लगता है, मतलब antidepressants चल जाता है. And research have proven now and then how SSRI has caused so many sexual dysfunctioning. So as physicians, we should not just be prescribing medication, but really guiding them. And our focus should be pleasure-based sex, not just medicine-based sex. So in this client, stage therapy, sex guidance is very important, and focusing on pleasure, not on performance, will help.
Here also, I just wanted to add and tell our audience that always this sexual problem is not like a female sexual problem or a male sexual problem. It's always a couple therapy and couple problem. We should not regard it as a female sexual problem. So whenever you deal with this type of patients, even I told you today, I am just getting this almost this similar case. Marriage life for 2 years and unconjugated marriage, same history. And the lady come with her mother and not with her husband. So I advise her to come with her husband because we have to take a lot of history from the husband too. So this is always that to the audience. I just want to, whenever the patient comes, because many times we are getting the patient like when the husband is only coming or the wife is only coming. husband wife should come together and we should sit and we should tell about and take the history. So this is a very important bottom line message which Anita ma'am want to tell.
Sometimes get to husband in our clinic is a very big problem because they usually don't agree to come.
Yeah, actually, this is fully agree with you, sir.
Next one.
Yeah, next question.
So we comes another case.
Yes.
28-year-old come to clinic and burst in crying because her husband talks down on her for not having sex. And she had a baby few months ago. Suppose 6 months ago she has a delivery. So how will you tackle this patient?
Yes, sir. Again, wonderful case. Patient postpartum, lot of body changes, lot of hormone changes, postpartum blues, postpartum depression. So here we talk about how body image can really affect sexual functioning because the woman thinks she is not attractive anymore. She's got stretch marks all over her body. She's not beautiful. She's not capable of sex. So here is, again, psychoeducation, that this is a normal change in the body. So psychoeducation in this client is very important, giving her that encouragement, empowerment, that these body changes are bound to happen because you had a baby. You can work towards getting a more fit, physical fit lifestyle by your behavioral and lifestyle changes. But again, this is about body changes. Good therapy here is a wonderful therapy which will work for these type of client and client who have any type of body image issues. Okay, sir. When you go to take a shower in the bathroom, keep a picture of how would you want to look or how you looked in your best form. Okay, this has been shown as a very motivating therapy, a mirror therapy in cases which have body image issues. So this is kind of like, again, psychoeducating the client about what body changes happen as postpartum and how the body is going to change. Creating a positive image is putting a picture in front of you, looking at the picture. This creates a positive reinforcement. Getting back into physical fit lifestyle can help. In this particular client, I would also like to rule out postpartum depression, sir. It was a very common condition because there's a lot of hormonal fluctuation happening. There is a change in the woman's role. She's up all night, feeding, pressure from the husband, pressure from everybody during this part of the in her life. So sometimes even clients can need antidepressants. So there are various in this situation. I would say once if you've tackled the issue of body image and you want to tackle depression, best is guide the client to a psychiatrist who would be able to put her on antidepressant. 6 months treatment, sir, works wonderfully well in cases of postpartum depression.
And
so
go ahead.
So as a gynecologist, you can work on the body image issue, give them this very simple technique. I know, like the support, I know that you're feeling these changes. Mirror ke samne ek wonderful picture lagao and keep on motivating them towards a healthy lifestyle, active lifestyle, and moving on to more physical fitness.
Ma'am, Dr. Anita, one more issue in such cases is that new mother has a lot of their attention is to baby, and they basically forget about their sex life and they ignore their husband. So basically, what advice you give if there is a such scenario? Because many a time it is because of their attention is more toward the baby, right?
And sir, again, this reminds me of the same case जो मैंने आपको पहले बताया था. We had a case in Harvard where the husband feels neglected also.
Yeah.
So this is again, we have to educate our clients that this is bound to happen. We encourage them to be more intimate with each other. Okay, spend more time with each other. Make roles. Okay, this is the time I will take care of the baby. This is the time you take care of the baby. Because if the mother has to take care of the baby in the night, in the day, it is very stressful for her. And super added with the hormonal changes and the postpartum blue, boom, it is a big explosion there. So encouraging the clients to first of all is educating them that this is an hormonal issue happening. This is a normal physiological change. This depression is caused due to the hormonal change, and this can be treated. Second thing is couples therapy, how they can come together, make time for each other, make time for this new role in life, and how to get intimacy back. So both feel neglected, sir. Even the wife feels neglected because she's playing this role raat din, and the husband feels neglected that, my God, this child has come. So couples therapy works wonderfully well, sir, in this situation.
Right.
Ma'am, just wanted to say, you are talking about the depression. So what all antidepressant and how many doses are actually safe in these type of cases, because he is breastfeeding? And is there is any role of antidepressant in this type of case? What you have told is yes. Yeah.
So Apurva, this is again some psychiatric knowledge, but let me quickly give it to you. Postpartum blues, like postpartum depression, has 3 levels. There will be just mild situations where the person feels depressed, feels less motivated. There could be moderate, or there are situations where women have suffered from severe depression, crying, yelling, killing each other, suicidal ideation. All these 3 situations are tackled in very different ways, friend. So if a person is suicidal, then they need serious intervention, because the most important rule of psychiatry is harm to self and harm to others. So if somebody is suicidal, can be a harm to self, or some can be harm to others. So they need very severe interventions. But if it is a milder case, okay, Apurva, if it is a milder case, then again, psychotherapy, supportive therapy, some simple behavioral modifications from the husband and the wife can take care of the mild part. बीच में आया है moderate part. In this situation, you will need a psychiatrist who can prescribe antidepressants. Now, I can give you a list of antidepressants, but unfortunately, I have seen that prescribing antidepressants, right, even in moderate cases, have led to a lot of sexual side effects in future. So the safer ones, again, I'm telling you the safer ones, which we all know. There is buspirone, there's bupropion, which have been safer with less sexual side effects. But again, the SSRIs have also worked very well for a short term. But unless and until you are very comfortable in prescribing antidepressants, one should sincerely refer it to a psychiatrist, because you don't want somebody to have a long-term low sexual dysfunctioning. So milder case rahega, you know how to handle it, supportive therapy, talk therapy, and behavioral modification, lifestyle changes. Severe cases need intervention, hospitalization. Middle cases, refer to a psychiatrist, start them on antidepressant, couple months therapy, they are fine.
Apurva, how commonly have you seen the postpartum depression? Because I don't know, I have not seen much of the postpartum depression in my patients. So how frequently do you encounter?
Sir, basically what's the problem? Because my area where I am practicing is, it's not very developed.
Yeah.
It's a very small places. So the problem is that now she has kid. Okay, the husband is demanding to have a sex. The kid wants attention. There's a lot of family problems. Lot of family, mother-in-law, the all family wants, okay, do your work, do things. So these all are collective, have a lots and lot of actually these type of depression, because they don't have, household worker to work with them. So that lady who is just give birth to a baby with all those pain, 9 months, and she has the problem with the husband is demanding, baby is demanding, and she has also the household work. She has to take care of herself, take care of her baby, has to satisfy her husband, and as well as take care of whole family. Now here comes the problem. So what I feel, these type of postpartum depression and these type of things are more common in a middle class and somewhat low middle class family than in the upper middle class family. The problem is this.
What you said, Dr. Yes, you would like to know.
Lovely, Apurva. I love your explanation, but unfortunately, that is so not true, my friend. Sad part is, sir, sad part is that when women have postpartum depression, this is not a very talked about condition. Even the psychiatrist, for that matter, I think you will agree with me, sir. अगर कोई client आपके पास postpartum आती है, how many times do you really ask the client, आपको रात में नींद आती है, आपको उदासी फील होती है, आपको बहुत रोना आता है आजकल, हमेशा थकान सी रहती है आपको? एंड इट इज अ सिचुएशन हियर सर, जब इट विल बी अ नॉर्मल चेंज बिकॉज रात भर जाग के दूध पिला के और बहुत सिचुएशन, बट देर आर सिचुएशन व्हेन दिस इज डिप्रेशन एंड nobody knows how to distinguish. So it is such a common condition, sir. It is such a common condition, not talked about, and most of the time the doctors don't know about it. सो अपूर्वा जी जो आप कह रहे हो वो सिचुएशनल चीज जरूर होती है कि भाई रात भर जाग के दूध पिलाना, बहुत खाना बनाना, रोल्स प्ले करना, बट यस डिप्रेशन इज अ वेरी कॉमन कंडीशन, पोस्टपार्टम डिप्रेशन. Milder form, possibly much more common, and
Much
then
more common.
severe form, then the
Correct.
severe suicidal forms. But again, very common, and I hope all my friends who are listening today would put that in their protocol, that if you have somebody come postpartum, make it a point to ask all these questions of depression. Do you feel sad? Do you feel hopeless? Do you have low mood? Has it been different from the being, before having a baby? And that will help you, you know, because sometimes it is just the support and comfort the client would need. And if you get to know, yes doctor, मेरे को बहुत डिप्रेशन होता है और बहुत रोना आता है, कभी कभी मन करता है अपने आप को मार डालो, you know where to direct the client. And if you have all those symptoms, so it is a very common condition, Dr. Jadhav, more common than we know.
Ma'am, we already passed the time, and we have lots of cases. Such a interesting cases are going on.
You can take that menopausal case.
Yeah.
Quickly, let me. Sir, मैं घुमाती हूँ, 1 मिनट रुकिए जरा.
Yeah.
Okay. So this is a case of COVID situation, and again a situational condition. We just talked about the various role a woman is having. So this person was referred to me, sir. Professional lady, was in a very professional role before COVID. COVID hit, job chala gaya, doesn't know how to adjust to the situation, havoc in their sex life, doesn't feel like having sex, blames the husband all the time. Again, situational condition. So this client would just need psychotherapy, would just need more of some help and guidance towards the sex therapy side, how they can bring sex in their life, put job and something, because if she's lost a job and she is feeling depressed because of that particular situation, a good counseling session, in 1 or 2 counseling session, can take care of this condition. So again, loss of professional role, housewife condition, very common condition everybody faces. Refer them to a psychologist for a counseling session. Here you go. So again, this is a postpartum condition, sir. We just discussed in detail. Okay, about this. Yes. Then we have this. This is a case, and again, this is again a very common condition, sir, where so here I would like to tell everybody that why men have sex and why women have sex are 2 complete reasons. Okay, men can have for physical reasons, women have more for emotional, comforting reasons. Now, this particular client says that he wants to have sex all the time because for him it is more satisfying. This is the way he connects to his wife, whereas the wife says, I want more of him. Again, here in this situation, we can help them with a lot of couples therapy, sex therapy, guiding them about what sex position each like, because this client of mine wanted to try out positions which was physically not possible with the wife, and secondly was not acceptable to the wife. So we had to have a couple session where they communicated each other's needs to each other rather than forcing. So rather than forcing that this is how I want to do it, and the wife says, oh, now I don't want to have sex with you because you said this. Talking to the client, putting up their expectation, discussing their sexual needs is very important in this client. So this client can be certainly tackled with a good sex therapy and couple counseling sessions, because you cannot give medicines or any pharmacotherapy for somebody who wants to try different sexual positions. Certainly in this situation, I should also put forward another theory, which is called as a desire discrepancy. Okay. The husband might come to say, madam, but she never wants to have sex. I want to have sex 5 times a day, 5 times a week, sorry. And sometimes people do have, but 5 times a week. And the wife says, no, but I feel comfortable with only 2 times. So here is a desire discrepancy. Somebody wants to have more sex, somebody wants to have less sex. As a physician, you need to create a communication, a good communication with them, like what is more respectful and what is more comfortable for you. Because you having sex or wanting to have sex 5 times is not wrong. She wanting to have sex 2 times is not wrong. It is just your different desires. So I'll give you a good treatment which recently we had, and this is what conclusion came from this client, and I don't want to be put up on the focus right now, but both my clients, right, the husband and wife, the wife said, madam, 2 times or 3 times is what I would like. My husband would like to have 7 days a week. This is not what I have. And they opened their relationship. I'm not saying that you should do that, but these are certain treatments which sometimes have to be given to the client, because nothing is wrong here. It is just a discrepancy. So it is very important for you to talk to the clients that no two people can be same. And you should not give treatment or medication to one client to bring somebody's sex up and somebody's sex down, because that's not what is a normal desire. Okay. So desire discrepancy, 5 years of marriage. We just talked about this, how different roles in life. Let's move on.
Yes. Let me finish. 13 number.
Oh, yes. So again, this is and again a psychological or one of when I talk about the biopsychosocial model, this doesn't seem to be a biological problem, but certainly she's reaching pre-menopause. So this could be a case where she's reaching pre-menopause, affecting her desire level, affecting her vaginal lubrication. But when you look at this case, she is a widow, and she suddenly is into a relationship. So a good counselor would be able to really find out if she is still attached to the previous relationship. What trauma did she have? How did she overcome the grief in this relationship when she lost her husband? And making a bond, a sexual bond, a sexual open mutual communication bond in this couple will help bringing sex back into their life. Because if it is premenopausal, we can certainly work on some hormones. It can help. If it is just a case of not overcoming the grief, not completely getting into the relationship, then sex therapy can help in this client. There was one case, sir, which was about not this case. There was another case where let's talk about this. So this is a case, 52-year-old. Surely she's into her menopause. She has hormonal fluctuation. She has hormonal issues, which has led to decreased desire, has led to physical symptoms of vaginal atrophy, vaginal dryness, surely causing pain during sex. Okay. And of course, we have another factor because there is obesity involved. We were just having a big discussion about a case like this recently. So this case, let's tackle this it again in a way of focusing on the biopsychosexual model. Okay, this is biopsycho and sexual. We are not talking about social model here, but biological model is what are the hormonal changes happening in this lady. So we do the hormonal profile, look into what is happening with the hormones. If the hormones have to be fixed, we know that there is estrogen hormonal therapy available, there is testosterone available. So you guys are more aware of those treatment modalities. You can give estrogen that can ease out to the vaginal symptoms, vaginal atrophy. We have testosterone. Nowadays, testosterone has also come in combination. We have combination therapy where PD5 inhibitors are combined with antidepressants and have worked wonderfully well with sexual desire issues in pre and postmenopausal women. That is there. That is the hormonal therapy, psychiatric therapy. In this situation, sir, also I would like to bring about the psychological factor. So as somebody who's gone into menopause, she already is feeling low on herself, on her body images. She's already feeling low, maybe possibly due to mild depression, because that's what estrogen can do. Okay, so not necessarily putting her into an antidepressant, but again, a counseling session, a psychosexual therapy session will really help in this case. Secondly, very important is losing weight, because weight and obesity kind of really affects the body image issue, and the person doesn't feel motivated to have sex. So guiding a lifestyle change, behavioral modification, active life is very important, because as we all know, somebody who is obese, not active, will not be will tend to have less activity even during sexuality. They would be reluctant to try different position in sex, wouldn't want to encourage in daily sexual activity. So it is a proven factor. So active sexual lifestyle, a little behavioral change, hormonal therapy. Okay, and again, we have different sex models, sex therapy models, which can be used in old age patients, so their sex life is longeved. There's a longevity created in the life. So this is a case of menopause, hormonal change. We can tackle this with these issues, with these treatments. There was one case which I wanted to talk and which Apurva brought to my notice. Apurva, do I have permission to go 5 more minutes?
Yeah, definitely, ma'am, definitely.
So, Apurva ji, you mentioned a very important case right now, that sometimes it's not the woman who has a sexual problem. It can be the male partner. So that brings me to another case which I am recently with. So this beautiful couple comes to me. The wife doesn't want to have sex. The complete focus was wife talking about the desire. Now, when we dig into the history, it turns out the husband has erectile issues. So that means we have a partner who already has a sexual dysfunction. Now it has become an adapted response of the wife. So wife कहती है, Madam, I don't want to have sex because he feels bad. He feels low. He feels that he is not capable of providing. So so gradually in so many years, I have suppressed my desire, and now I don't feel like having desire. So what do you do in such a situation? Okay, here we don't have to target the women. We don't have to target the man. We have to target them together. We have to deal this client as a couple's client. We work on the husband who has a sexual dysfunction. If he has erection issues, ejaculation issues, we work on those. And at the same time, we start working on the wife. Okay, if the wife has any other condition other than just low desire, which has a adaptive response, we try to bring sex in their life with various sex therapy and couples therapy. Okay, but if the wife also has something which needs biological or pharmacology treatment, we work on pharmacology as well. So Here is a condition where the primary cause is the husband. It has led to sexual dysfunction in the wife. We treat both of them together simultaneously.
Right. So thank you, Dr. Amita. So bottom line, I think is that in majority of cases, desire and interest disorder can be treated with the counseling only. No.
And detailed history taking is very important because there may be some. It's not always that it's an organic cause. Maybe some psychological cause. And as you already told, ma'am, it's a couple therapy certainly for that. Yeah.
Yeah, and I must tell you, we were recently in a conversation and people talk about flibansery and release, and they have now even a lot of research says it really doesn't work a lot.
And ma'am, what about sildenafil? What about sildenafil? Because many a time, few years back, there's a very huge, yeah, it is for the female sexual desire also. So what's your, experience or what's your advice? Use sildenafil in a low dose 25 mg for the female sexual desire.
See, Apurva, I have physicians, my friends who work in India and who have tried this with amazing results. Okay, I haven't tried it yet. I usually, because I feel sex is just not very physical. So we work more on the sex therapy side than really going on the pharmacological side. So giving PD5 inhibitors to women, I will still be reluctant on that. Though I know the anatomy, I know about the erectile functioning, the clitoral, everything, but I will still be reluctant in using it. Says that, do my friends and colleagues have used it? Yes. Have they seen results? Some good results, some not so good results.
Ma'am, I have, yes, sir, Neeraj sir, you want to
recently there is a one launch of the product which contains nitric oxide. So how useful is that nitric oxide? Have you ever come?
No, sir. No, sir. I'll quickly go through my slides and I'll tell you. I think you guys can just look into these slides for all the pharmacological treatment. This is a wonderful treatment it has been worked for us so many years about how orgasm has brought desire in women back. So continuous orgasm. This is an orgasm protocol. Anybody's interested, please look into this. A nice staged program which is used for desire and orgasm, sex therapy part, and I will quickly go through the pharmacological part. These are available, sir. Okay. I know Dr. Jumani has mentioned several times to me that he loves to add DHEA treatment and it has worked wonders with his patient. Flibanserin, Willis, Bermelatin, we don't know much. It came up with promising results, sir. It came up with promising, but not much to be seen. PD5 inhibitors have shown results. Again, I told you, my colleagues, my friends use it. Iffy results, some good, some bad. Nobody can really say 100% it is going to work, because even I have clients, male clients, who have no issue, psychological erection problem, PD5 have not worked, and where sex therapy has worked. So nobody can say this is going to work. We have combination, we have bupropion, we have estrogen gels, estrogen gels, oral treatment available for menopausal symptoms, as we just discussed. Even clients with premenopausal conditions nowadays, sir, बहुत लोगों को there's decreased hormonal level, and even they have tried estrogen in premenopausal women as well. Again, see, here is sildenafil. We have testosterone. What I would really encourage, sir, someday, if you guys, and this is a combination treatment available in India, testosterone with sildenafil. Again, we don't know the results. I don't know. I have my teachers and colleagues use it. Everybody gives me
libido. What is the dose? Can you just...
Sir, I haven't used it, sir, but this is available in the Indian market.
Okay.
I haven't used these combinations, sir.
Okay.
But there is something which we lack, and I think if our physicians who are interested in the field of sexual medicine, something very important is missed in this whole place is, sir, we focus a lot upon pharmacology, but we do not focus on pleasure accessories. Okay, and India, I know it is illegal sex toys, sex accessories used. That's why there's so much of pharmacology used. But I'll tell you, women with low sex desire. I hope I'm going to have a series of training in this part. But women with low sex desire, we have vibrators, there are bullets, there are clitoral stimulation mechanisms, machines, and they work wonderfully, sir.
Basically, it is for orgasmic disorder or for desire disorder?
Even, sir, now again, we're talking about how from arousal the desire can come, right? So if there is a stimulation happening and there are devices available, there are jellies which give you warm feeling. So I prescribe my clients here and all around the world, there are jellies available which gives warm feeling, which causes arousal, and there is desire to have sex. So there are so many non-pharmacological treatments available, and if people have that knowledge, they can use it rather than really sticking to pharmacological treatment. And I tend to avoid that, sir, all the time. So I'm going to have a series of training for people how our physicians are trained into pleasure accessories and how they can show their clients to use it. Very simple devices, sir, very simple. And before I leave, there is my first slide, which had all the pictures, all the Bollywood movies and very good educational things. There is one picture of a woman. Again, her husband probably had premature ejaculation, or it was more mechanical. And she was shown use sex accessories for self-pleasure. So self-pleasure is a big thing, friends. Encourage your clients. Talk to your clients about the benefits of sex, how to have self-pleasure, how to use accessories in their life, because soon it gets monotonous, desire goes down, and you want to spice it up with different things.
Thank you, Dr. Anita.
I know it is, sir. I wish we had like 10 hours to discuss.
Yeah, and it was so interesting. Actually, we already finished 2 hours and we are talking, abhi just start hua hai. It was so mesmerizing and such a, these are all the live questions, which we are feeling, which we are getting in our day-to-day life.
Dr. Anita, can you stop the segment?
Ma'am, stop sharing, please.
Okay.
Yeah. So, sir, I think we already passed the time, and
if there is any interesting question, just you can.
Yeah, let's
sir,
take.
actually, kuch questions the, but what Lai informed me that we already covered that. So actually, there is no question, and actually, madam covered all the things so beautifully. I think each and every aspects of this arousal and interest disorder, I think there's nothing left in that.
So
there is still so much, Apurva. I wish we had, I always say that I wish we have more time, because sadly, the media focuses so much on sex as a mechanical part, and there is so much importance given to pharmacology, but there's so much more to do. There is really so much more to do.
But hardly there is anything available for the female sexual dysfunction as far as pharmacology is concerned. There are so many drugs available for male dysfunction, but very few in female.
Yes, sir, because it is so multifactorial, sir. There is not one thing in a desire which can be really pinpointed. If I take care of this, this is going to work. That is just not possible. And desire is such a vast topic in all. I remember, sir, if you remember our first class, Dr. Jindal saying, women are so complicated and men are so simple. That is so true. That is so true. The desire part is so complex. And that's why, I always tell all people, there are people who reach out to me, sir, and madam, can I give this medicine and desire aa jayega? Well, no, it's not that simple. And when we go into the detail, we'll say, oh, wow, this is an ocean and there's so much to offer to our clients.
Yes, definitely. So, Apurva, can we finish with the vote of thanks? You have to unmute. Oh,
yes. Yes, sir. Actually, sir, मेरा बेटा आ गया. So thank you so much to. I'm extremely sorry, sir.
no.
So thank you so much to our President, Dr. Shanta Kumari ma'am, Secretary General and Chief Guest for today, Dr. Madhuri Patel ma'am, and the Vice President in charge, Dr. Vipin Pandit sir, and the chairperson, the man behind every this show, our own Dr. Neeraj Jadhav sir. And last but not the least, Dr. Anisha Shyam ma'am, our dynamic faculty and speaker. It's always being awesome with you, ma'am. And definitely the ICOG chairperson Uday Thanewala sir and the secretary Ashok Kumar sir for grant us 1 credit point, and to all the audience to have such a beautiful audience for seeing us and giving their feedback. And last but not the least, our partner, that is the INTAS partner Lai and all the Rohit and all supportive team for giving us the platform and for being so good and organizing such a wonderful webinar. Thank you so much. And sir, anything you wants to?
No.
Yes, sir.
And thank you to Mr. Satpati ji of the INTAS Pharma, who always there to support us. This is our second session series of with the INTAS Pharma, and they are so kind enough to permit us to have an academic grant from their part. Otherwise, it's not possible to
have this definitely
long series.
Definitely.
So thank you everyone, and have a good time and a happy Janmashtami.
Definitely, sir. And to all the viewers, we will come up with our next very interesting case history with this type of discussion and with some great faculty with us. So stay tuned with us, and we will definitely reply you back, and we will inform you for our next session too. Thank you so much.
Don't forget to join our Facebook group, Sexual Medicine Committee FOXI, and our Facebook page of Sexual Medicine Committee to get all the update about this, our upcoming scientific sessions. So be in touch with us.
Thank you.
Thank you.